Well, good morning, everybody. Welcome to another Grand Rounds. It's my pleasure to welcome you all here. We have a very special speaker with us this morning, Dr. Thomas Schaumberg, who is works at the Oregon Clinic in Pulmonary and Critical Care. He's also one of our intensive care unit specialists. He's been the executive vice president of the Oregon Clinic. He's worked as the medical director of critical care at Providence. He's also worked at Southwest Washington Medical Center, the Vancouver Clinic. He did his medical school at the University of Colorado, his medicine internship and residency at OHSU, and then fellowship in pulmonary and critical care at UC San Francisco. He's been awarded many teaching awards, Teacher of the Year. You may have seen his face on buses, I believe, around town as one of the best doctors of Portland, repeatedly voted that. He was always one of my favorite attendings in the ICU, where I felt like I was being taught by a silver-haired Bruce Wayne with a lovely deep voice. And he's here to talk to us today about drug-induced lung disease. Welcome, Dr. Schaumberg.
Thank you. I just want to make sure, is the microphone on? Can you hear me at all? No. Okay. I may need a little help from AV. It says we're on. Okay. How about now? Can you hear me? I'm getting some no's in the back. Can you hear me? Okay. So thanks for the opportunity to speak today. I wanted to take this chance to talk about drug-induced interstitial lung disease, but I wanted to focus on a couple of issues that I think are very well known to all of you, but are often overlooked or misunderstood. And I'm also going to spend a little bit of time specifically talking about what I think is an increasingly emerging issue that's going to come up, and I think all of you will be exposed to throughout your practice. So I do receive compensation as a principal investigator for clinical research in interstitial lung disease, but none of those issues really are in conflict with today's discussion. So this is a very broad topic, and there's over 1,300 different agents that have been associated with drug-induced interstitial lung disease. Fortunately, less than about a third of those have been associated with any significant number of case reports, and most of them are just incidental case reports. Airways disease and interstitial lung disease are far and away the most common presentations for drug-induced lung disease, and specifically cough. Of course, you're all very aware of ACE inhibitors causing cough, and that ARBs don't cause cough, but there's also problems with bronchoconstriction, which is a common issue for drug-induced lung disease as well. As I mentioned, interstitial lung disease is the other common presentation for drug-induced lung disease, and specifically cancer drugs. I'm going to be talking more about cancer drugs throughout the rest of the day today, as well as medications like antibiotics, antiarrhythmics, and particularly amiodarone. There's also parenchymal lung disease that can cause pulmonary edema and alveolar hemorrhage, and I'm not going to spend any time talking about those topics. And of course, pleural disease, pulmonary vascular disease, lymphadenopathy, and systemic diseases that cause respiratory symptoms are other categories of lung disease. Again, this is a huge topic, far too broad for me to be able to cover in any significant depth. So the question is if you're out there in practice, what do you do when you have a question about whether there's a drug that's involved with your patient's symptoms? If you leave this Grand Rounds discussion with one thing that you remember, what I want you to remember is pneumatox.com. This is a website that's continuously updated. It's updated from France. And when you go on to the splash screen for the pneumatox.com, you'll see that there are these stars beside each of the different drugs. And unlike Yelp, the 5-star rating is not good. A 5-star rating means that there's more than 200 case reports or cases that are associated with that specific drug in interstitial lung disease and that specific drug. If the easiest way to use this website, though, is to use the search, and let's say you have a patient who has frequent urinary tract infections, and you put her on nitrofurantoin, and she comes back a few days later and is complaining of cough and increasing shortness of breath. And you're wondering, is that drug associated with her symptoms? You can put in the medication into the search file, and lo and behold, for example, if you put up nitrofurantoin, you see that it has a 5-star rating, meaning there's more than 200 cases associated with lung disease associated with nitrofurantoin. But you also see all of these boxes with these Roman numerals. And the Roman numerals are associated with a specific type of lung disease involvement, interstitial lung disease, airway involvement, vasculopathies, etc. If you hover over one of these boxes, you'll get this pop-up that tells you exactly what type of lung disease is associated with that medication. If you click one of those boxes, then you get the specific type of lung disease. And in this case, there's still 100 to 200 case reports of interstitial lung disease, specifically pulmonary fibrosis, associated with nitrofurantoin. One of the nice things then is you have these references that you can have direct links to about that disease. So if you remember anything about this lecture, I want you to remember pneumatox.com. But while I have your attention, let me tell you a little bit about nitrofurantoin toxicity. It comes in 2 different forms. The most common is acute toxicity, and it's similar to hypersensitive pneumonitis, in that people present with fever, shortness of breath, and non-productive cough, and it's often associated with eosinophilia, but not always, and usually has ground glass opacities. You can also have a chronic form of nitrofurantoin lung as well, and it's a more insidious onset of dyspnea, cough, and fever, and is more difficult to identify, and usually just requires knowing that nitrofurantoin causes pulmonary toxicity. Let me get started in talking about a couple of specific issues I wanted to bring up by going through a case presentation. And this woman is a woman I had actually seen before. She's very educated and spends a lot of time doing research on the internet, and actually came to me, or back to me I should say, because I had seen her before. She had been a previous smoker and had recurrent exacerbations, and it turns out that she, in addition to COPD, she had asthma overlap, so asthma with COPD. And she was concerned when I first saw her about using inhaled steroids because of her glaucoma and because of her osteoporosis. She ended up going on inhaled steroids and a long-acting beta agonist and did quite well until a few months before she saw me again, when she was complaining of a persistent cough, shortness of breath, and had been treated with antibiotics and steroids a couple times by her primary care physician, but still wasn't getting any better. She did not have any symptoms of acute infection, and she was on fluticasone and salmeterol high dose twice a day, albuterol, over-the-counter antihistamines, losartan, metformin, Protonix, ibuprofen as needed. She had a lot of osteoarthritis and took the ibuprofen frequently. She had eye drops for her glaucoma. She didn't know the name, and vitamin D and calcium. When I'd seen her before, she clearly had moderate obstructive disease with a 14% bronchodilator response. So she's one of these patients who has asthma COPD overlap. When I saw her this last year, she had a little bit worse airway obstruction with a decrease in her FEV1 and had minimal bronchodilator response at that time. Previously, she had had an elevated IgE with moderate reactions to a number of different allergens. Her white count when she was seen at the urgent care clinic was notable for mild eosinophilia with an elevated absolute eosinophil count as well as elevated percent eosinophils. Her x-ray was unremarkable. Excuse me. So the question comes, what do you do next? Well, the drug that she had heard about on TV was mepolizumab or Nucala, and she came asking her doctor if it was right for her. And so that'd be one choice. Or the other choice would be perhaps maybe you want to start omalizumab, which is Xolair, and is an anti-IgE treatment. Maybe this is aspirin exacerbated respiratory disease, and you should switch your ibuprofen to Celebrex, or you can start a LAMA, or none of the above. So I'm going to use this to talk a little bit more about aspirin-exacerbated respiratory disease. So there's 19 million patients who have asthma, and about 7% of those patients will end up having aspirin-exacerbated respiratory disease. If you look at patients who have severe asthma, about 15% of those will have aspirin-associated disease. If you look at people who just have nasal polyps, it's about 9%. And that was always the triad that I was taught, was a combination of asthma and nasal polyps. And a couple of specific comments about aspirin-associated respiratory disease and the clinical characteristics. One of the key features that these are people who have recurrent polyps. So they'll have resection of their polyps, and year or 2 years later, they'll have recurrence of their polyps and require recurrent surgeries. So one of the key things is if you have patients who have recurring polyps and require recurring surgeries, that's a clue that they have aspirin-associated disease. Interestingly, most of these patients will also have similar reactions, runny nose, wheezing, shortness of breath, associated with beer and wine. Not alcohol, but beer and wine in particular. It's not clear what it is about beer and wine that causes the problems. Now, if you get a CT scan and you see complete opacification of the passageways and the sinuses, and they have asthma, those people, about 42% of them will have aspirin-associated disease. The flip side of that is there's a lot of people that I have traditionally said, oh, don't take any aspirin. You've got polyps and asthma because you could have aspirin-associated lung disease. In reality, they don't. But if somebody says, I had episodes of flushing, shortness of breath, wheezing after I took a nonsteroidal, that's a good clue that they have had problems with aspirin-associated lung disease. But the onset is about 90 minutes, within 90 minutes of the time they took it. Interestingly, aspirin-associated respiratory disease is acquired. There's no specific gene that's associated with it, and it usually develops as people have worsening asthma, and typically the age of onset is about 30 years. And it is associated with allergic diseases. So this is a subtype of inflammatory asthma associated with eosinophilia, or type 2H asthma with eosinophilia. The hives and urticaria that are associated with some patients with aspirin sensitivity is caused by a totally different reaction. So all cyclooxygenase inhibitors, COX-1 inhibitors, can cause aspirin-associated respiratory disease. Aspirin permanently inhibits the cyclooxygenase and will inhibit the cyclooxygenase activity until it's regenerated, which takes about 2 to 3 days. Nonsteroidals, on the other hand, are competitive inhibitors with the receptors, and the side effects last as long as the medication itself. So, when I finished my fellowship, I was required to sign a release form that said that anytime I spoke about asthma, I had to show some complex inflammatory pathway. So I'm going to do my due diligence here. But what I want you to remember are, first of all, there are several different phenotypes of asthma. There's Th2 inflammation, which is associated with allergic asthma and eosinophilia. There's neutrophil inflammation that's caused by irritants, viruses, infection without eosinophilia. There's obviously a mixed type, and there's this paucigranulocytic inflammation that's typically associated with patients who are overweight or patients who had previously poorly treated asthma or COPD and have chronic inflammation and hypertrophy of the smooth muscles. And there's also aspirin-exacerbated respiratory disease. So there's these different phenotypes, and there's overlaps between all these phenotypes. And leukotrienes in particular, which are affected by nonsteroidals, are just one part of this inflammatory, one type of the phenotypes, and it is associated with the eosinophilic phenotype in particular. So here's this slide that I was talking about. Arachidonic acid is an internal cellular signaling molecule that helps regulate inflammatory and anti-inflammatory pathways. Specifically, arachidonic acid can be metabolized in 2 different pathways. one to prostaglandin E2, and the other through the 5-lipoxygenase pathway that leads to the production of leukotrienes. The leukotriene pathway tends to be inflammatory, whereas the prostaglandin tends to be somewhat anti-inflammatory. And it turns out that patients who have aspirin-associated disease naturally produce less COX-2, and so more of their arachidonic acid is pushed over to the leukotriene pathway, causing more inflammation. When those patients take a non-steroidal, they then fully inhibit the COX-1 inhibitor, and the result is that all of the arachidonic acid is metabolized into leukotrienes and causes an increase in inflammation. The prostaglandin E2 also downregulates the 5-lipoxygenase pathway, and so it's also inhibited when you take a COX inhibitor. So the leukotrienes themselves then cause upregulation of mast cells, lymphocytes, eosinophils, and the leukotrienes then can cause airway edema as well as airway obstruction, and can cause mucus production as well, which are the hallmarks of the symptoms of bronchoconstriction, flushing, as well as the rhinitis and increased mucus production. All NSAIDs are highly selective COX-1 inhibitors. In general, it takes about half an hour for the symptoms to start after you take one of the non-steroidals. Ketorolac, which is given IV, it takes about 15 minutes for the symptoms to start. Celebrex is a highly selective COX-2 inhibitor, and is selective specifically for the COX-2 enzyme, which is already decreased in patients who have aspirin-associated respiratory disease, and so are safe in patients who have aspirin-associated respiratory disease. In general, the diagnosis is made by a combination of a history. As I mentioned, if they have a history of reaction, there's about an 80% chance that they will actually have aspirin-associated disease. If they have a history of polyps alone, about 10% chance. But if they have polyps and sinus opacification, there's about a 42% chance that they'll actually have asthma. Now, the definitive diagnosis is based on an oral aspirin challenge, and usually that's done at the same time as people get started on a desensitization program as well. The desensitization involves taking low doses of aspirin, usually starting at 20 milligrams, and increasing doses 3 times a day for the span of 3 days, usually done in an outpatient setting. The average provoking dose for patients who have aspirin-associated disease is about 60 milligrams, but that dose is not enough to completely inhibit the response. So that means that for those patients who are taking cardiovascular doses, 81 milligrams, they can self-desensitize, but if they take a much larger dose, they can still have a reaction to aspirin. So the treatment, one approach is to totally avoid any COX-1 inhibitors, and you can use Celebrex instead, which is safe to use in patients who have aspirin-associated disease. Leukotriene inhibitors are of particular interest, but it turns out that none of the leukotriene inhibitors completely inhibit the response. They simply attenuate it. And Xylutin in particular inhibits the entire pathway to the production of leukotrienes, whereas montelukast and zafirlukast only inhibit the receptors, but none of them completely block the effects. As I mentioned, aspirin desensitization is the ultimate treatment for it, and it's usually indicated for patients who have frequent polyposis or require non-steroidals because of cardiovascular disease or because of their arthritis. Now, the desensitization does not get rid of the polyps. It simply prevents them from growing back. So it's usually recommended that patients get a polypectomy before they go through the desensitization. Generally, this can be done as an outpatient, but for patients who've had a recent myocardial infarction, are on beta blockers, or have severe or uncontrolled asthma, it's usually done in a hospital setting, but does not require an ICU setting. As I mentioned, it's an escalating dose that's given over 3 days, and they start out with a placebo because there's about 20% of patients who will have paradoxical reactions that are not associated with the aspirin itself. Once they get desensitized, they have to take aspirin every day. There's a refractory period of about 72 hours. So if they miss 1 day or 2 days, they can simply resume taking aspirin. But if they miss more than 2 days in a row, they have to go through the desensitization again. There are a couple of physicians here in town that do the desensitization. Quite honestly, I usually refer my patients to OSU, mostly because of familiarity. So, in summary, aspirin-associated respiratory disease or aspirin-exacerbated respiratory disease is actually a subset of the Th2-mediated asthma or eosinophilic asthma. It's associated with recurrent polyposis, and that's one of the clues that you should look for. Interestingly, it's also associated with similar symptoms with beer and wine, and that's another historical feature that you can ask about. It's mediated by COX-2 inhibition and causes an increase in leukotriene production. Leukotriene inhibitors can help, but don't get rid of the symptoms entirely. And aspirin desensitization is very effective in these patients in helping control their asthma exacerbations, and improving their quality of life, decreasing their steroid use. And in short, it's much less expensive and much more effective than the newer biological agents. And so that's one of the take-home points I want you to leave with, is not only is particularly for patients who have asthma. Before you consider using one of the newer expensive biological agents, make sure you discuss the possibility about aspirin as an aspirin desensitization. So, so I'm going to make a transition now to beta blockers. And I'm sure all of you are familiar with beta blockers and the potential association with respiratory diseases, but I'm going to go into a little bit more detail. Specifically, are there any beta blockers that are safe for patients, or can any patient with asthma take beta blockers? Are there some beta blockers that are safer than others? How about COPD? Are beta blockers safe in COPD? How about patients with asthma and COPD overlap syndrome? What about beta blocker eye drops? Such a small dose. Are they safe? And if you do need to use beta blockers, what can you do to minimize the risk? So again, as a bit of a review, I want you to keep in mind that airway tone is a balance between the muscarinic effects from the vagus nerve that cause bronchoconstriction and the bronchodilating effects of the beta agonists. And there's a constant kind of tension, if you will, between these two pathways that maintains airway tone. And if you use a beta blocker, then it entirely blocks the bronchodilating effect of the beta agonist, and you then have unopposed bronchoconstriction caused by the muscarinic pathway. So this is a meta-analysis of 53 studies and over 500 patients in patients who had mild to moderate and stable asthma, and is a retrospective review of all the prospective studies that were done. And for those patients who have mild to moderate stable asthma, about 10% of them will have, they will have a 10% decline in their FEV1 associated with non-selective beta blockers, and about a 7% decline in the FEV1 with cardioselective beta blockers. So all beta blockers do cause some change in the airway tone and decrease in the FEV1, even though it may not be symptomatic. And importantly, too, when those same patients use a rescue inhaler, the response to the rescue inhaler is also blunted. In the non-selective beta blockers, it's almost completely blunted, whereas the cardioselective beta blockers, it's only partially blunted. And not every beta blocker is equivalent. So of the individual cardioselective beta blockers, for the ones that are available in the United States, it appears that atenolol is the one that's associated with the least decline in FEV1 and the least inhibition of the beta agonist response. What about eye drops? So there's only one cardioselective eye drop, if you will, and it's very expensive here in the United States, and timolol is still the most commonly prescribed eye drop for beta blockers. And patients who have asthma and use beta blocker or non-selective eye drops will get an almost 11% change in their FEV1. And the question is, this is such a small dose, how does that happen? As it turns out, what's probably happening is that it's directly absorbed through the mucosa and doesn't have to undergo first-pass metabolism. So even the dose is very small, the effect can be still very profound with eye drops. So, in summary, beta blockers should be avoided in asthma if possible. There are still significant effects with cardioselective beta blockers, but atenolol seems to be the one that has the least effect, and the effect is dose-related. So if you have to use a beta blocker, use the lowest dose. Eye drops do cause a significant bronchospasm, and the beta blockers also blunt the effectiveness of the response to inhaled beta agonists. Turns out that use of inhaled steroids or systemic steroids doesn't protect you from this side effect, but using an anticholinergic inhaler may help prevent the unopposed constriction caused by the muscarinic receptors. How about COPD? So a meta-analysis of 80 patients that were studied prospectively, of those patients, none of them had any significant change in FEV1 and didn't have a change in the response to beta agonists. And 6 prospective trials with patients with severe COPD and FEV1 of less than 50%, again, there was no significant change in FEV1 or increase in symptoms. And importantly, in a retrospective study of almost 6,000 patients, the use of beta blockers in patients with COPD actually led to a reduction in hospital admissions and a 22% decrease in overall mortality. So the take-home for beta blockers with COPD is it appears to be safe and, in fact, may be beneficial because there's such an overlap between patients who have cardiac disease and respiratory disease. What about asthma COPD overlap? Now, this is a phenotype, if you will, a category of patients who have some elements of COPD, but they also have significant eosinophilia and Th2 type inflammation. Typically, they have a history of allergies and will have bronchodilator responses on their FEV1 or will have a good response to steroids in the past. So the bottom line is a very limited number of studies looking at beta blockers in this patient population. And in general, if you have a patient who requires inhaled steroids because of their reactive component of their COPD, if they have eosinophilia, if they have documented reversibility, if they have a history of atopic disease in addition to their COPD, these are the patients where you should specifically try to avoid the use of beta blockers. So, back to my original patient, a couple of comments. It turns out that the correct answer in her case was none of the above. She had recently changed her insurance and changed her eye drops for her glaucoma and was now using timolol, and had caused an increase in her symptoms and shortness of breath, and talking to her ophthalmologist to change the eye drops was all that it took. A couple of comments I wanted to make, though. Mepolizumab or Nucala, there was a study that looked at patients who had overlap syndrome. There was some statistically significant benefit, but of unsure clinical benefit, and Nucala or mepolizumab has not been approved by the FDA for use in COPD with asthma. And all of the biologics, you should extensively review other potential causes for their poorly controlled asthma, such as noncompliance, sinus disease, reflux, and they should be on maximal therapy, including, the recommendations are at least, that they're on inhaled corticosteroid, a long-acting beta agonist, and adjunctive medications such as the leukotriene inhibitor or consideration of adding a LAMA. So I'm going to transition again to another topic that I wanted to spend a little bit more time on, and I think is probably unfamiliar to many of you, but is going to be an increasing issue as we go forward. So this is a 59-year-old man who has a 35-year history of smoking and stage 4 lung cancer. He previously was treated with standard palliative platinum-based chemotherapy and radiation therapy for his post-obstructive pneumonia and metastatic disease. Unfortunately, it had disease progression and was started on a new PD-1 inhibitor. Shortly thereafter, he was hospitalized with progressive hypoxemia, and during his hospitalization, he required as much as 90% oxygen with 60 liters flow with an Optiflow device. This is his chest x-ray when he presented with his cancer. He had a very large left upper lobe mass that was obstructing. It caused volume loss, but his right lung was unaffected. This was his x-ray at the time of his presentation. It actually had a pretty good response to the radiation therapy, but had these new diffuse nodular infiltrates on his x-ray and these diffuse infiltrates on his CT scan as well. One of the issues with this sort of presentation is, what the potential differential diagnosis is. And obviously, in a situation like this, the differential diagnosis will often include the question of infection or spread of the previous cancer, in addition to whether this could be a drug-related toxicity. So I wanted to spend a little bit more time and going in a little bit more detail about checkpoint inhibitors. Checkpoint inhibitors are a new class of medication that are being used to treat many different types of cancer, but specifically non-small cell lung cancer is where I come into exposure to it most frequently. And I wanted to explain a little bit more about what checkpoint inhibitors do and how they actually work. So normally, we have antigen-presenting cells that are phagocytize any antigen that happens to be around. They present the antigen they present the antigen to T cells, but the T cells, in order for them to become activated, they need to bind the antigen, but they also need to bind with proteins that are normally on the cell surface of the antigen-presenting cell. So it takes a combination of both the antigen and binding to the proteins from the antigen-presenting cell to trigger the T cell activation. Now, there are multiple normal, if you will, occurring down-regulating effects for T cells. One of them is if there is an abundance of antigen that is presented, it causes an upregulation of a T cell surface protein, a CTLA-4 protein, that causes downregulation of the T cell itself. So just over-presentation of antigen will cause a downregulation of the T cells. But there are also these PD-1 receptors that are on T cells. And if they are stimulated by binding to a either naturally occurring or a tumor-associated PD-L1 inhibitor, either PD-L1 or PD-L2, it causes programmed death, and that's what the initial is programmed death or apoptosis of the T cells, and causes downregulation of your innate immunity. So that's essentially what the idea behind any of the checkpoint inhibitors is to either affect the innate downregulation of the T cells through the CTLA-4 receptors or through the programmed DEF1 receptors. And PD-L1 induced lung disease in particular has been associated with a number of different cancers, and it turns out that there's no specific association with autoimmune reactions with the type of cancer itself. It is associated with the drug and not specifically the type of cancer. And we're seeing the use of PD-L1 inhibitors increasingly in non-small cell lung cancer, but as well as melanoma, renal cell, bladder cancer, head and neck cancer. And last month there was a report of using PD-L1 inhibitors in metastatic breast cancer as well that had a favorable outcome. This is a study that was published last year that looked at pembrolizumab in association with standard chemotherapy, platinum-based chemotherapy. And in this particular study, there was two different arms. They were 2-to-1 with either placebo in combination with standard platinum-based chemotherapy or pembrolizumab in combination with standard platinum-based chemotherapy. and there was a remarkable improvement in the overall survival in those patients who received pembrolizumab. And very interestingly and specifically, even in those patients who had very little PD-L1 tumor expression, there seemed to be benefit in those patients as well as those patients who had high levels of PD-L1 tumor expression. Again, implicating that the way that these medications work is not by directly affecting the cancer cells, but by affecting your innate immune response to those cancer cells. And it doesn't matter whether the cancer cells have the PD-L1 binding protein on them or not, because you're affecting the patient's T cell response, and that's how they work. So this has brought up a whole new class of drug toxicities associated with medications, specifically autoimmune-associated adverse response. And these adverse responses can affect essentially any organ of the body and have been reported with the use of these checkpoint inhibitors. Some of them are very common. In fact, skin rashes and vitiligo, particularly in melanoma, is very common, and some oncologists take it as a positive sign that you're getting a good response. Thyroid changes, both hyperthyroid and hypothyroid, are very common, as well as colitis and hepatitis. But pneumonitis occurs roughly between 4 and 10% of the time that patients are treated with these checkpoint inhibitors. But of the side effects, it is the one that is more commonly, it is the one that is associated with mortality. So there are a lot of different cancer drugs that have been well associated with interstitial lung disease and drug toxicity, bleomycin being one of the most common ones. But the checkpoint inhibitors are certainly the most recent ones, and there are increasing reports about use of checkpoint inhibitors in cancers. As I mentioned last month, a report of using checkpoint inhibitors in breast cancer, and I just happened to see that 2 days ago there was a report in the New England Journal about using checkpoint inhibitors for treatment of Jakob-Creutzfeldt disease as well. Overall, the incidence of pneumonitis associated with checkpoint inhibitors ranges between about 4% and 10%, but has the highest mortality of the autoimmune-related toxicities, up to 9%. Interestingly, it's not associated with the dose or the duration of the treatment and can occur anytime within a few weeks of the onset of treatment to months after the treatment. And there's no clearly defined risk factors. As I said, the risk of developing pneumonitis or autoimmune reaction to these checkpoint inhibitors are not associated with a specific underlying cancer, whether people are smokers or not. And I'll talk a little bit more about other autoimmune diseases in a second. The presentation is the same presentation you'd get with any interstitial lung disease: a dry, non-productive cough. Fevers are relatively uncommon. And they're usually associated with bilateral interstitial infiltrates, but the pattern on the CT scan can be any pattern. So you can see focal infiltrates as well as diffuse infiltrates. The bottom line, the pattern on the CT scan is not helpful to you in terms of making a diagnosis of whether this is a checkpoint inhibitor-associated disease. Bronchoscopy is generally helpful in ruling out infection, but otherwise there's no specific findings on bronchoscopy that's going to lead to a specific diagnosis, and the same is true with surgical lung biopsy. The pathology associated with interstitial lung disease from checkpoint inhibitors can look like cryptogenic organizing pneumonia, nonspecific interstitial pneumonia, hypersensitive pneumonitis. So in general, we don't proceed to surgical lung biopsy because there's not a specific pathological finding that can be associated with checkpoint inhibitors in particular. So ultimately, the diagnosis is a diagnosis of exclusion based on the temporally related exposure and ideally improvement with withdrawal of the drug. There's no specific pathological finding. There's no specific CT scan finding that you can use to make a confident diagnosis of checkpoint inhibitor-associated pneumonitis. So the treatment is to stop or to try to delay the treatment itself. And depending upon the severity, for patients who have more severe disease, we'll also use glucocorticoids. And typically it's a half milligram to a milligram per kilogram, up to about 60 milligrams per day. For patients who have colitis associated with checkpoint inhibitors, infliximab is commonly used, probably because of the experience of autoimmune or inflammatory bowel disease and the use of infliximab, and it seems to be effective. So what about those patients who do have an autoimmune reaction with one of these checkpoint inhibitors? As I mentioned, there are some oncologists who believe that having an autoimmune reaction is a good sign, and it means that the drug is actually working. Maybe that's just optimism that's spread by the oncologists, but that has not been shown to be true in non-small cell lung cancer in particular. In general, the outcomes for people who do have adverse immune reactions are the same in terms of their cancer survival and response to cancer as those patients who don't have any autoimmune reactions. So there doesn't seem to be any clear association with the benefit of the drug and whether you have an autoimmune reaction. The treatment of the adverse effects with steroids also doesn't seem to have a negative impact on the outcomes for treatment of their cancer, unlike some other immunotherapies, for example, using steroids for interferon-associated reactions. So most symptoms will resolve within weeks of stopping the medication, and again, depending on the severity of the response, we'll use steroids. And as an example, and in one study looking at 38 patients who had non-small cell lung cancer and had autoimmune reactions that required delay or steroids, and then were retreated, 50% of those patients who had a previous allergic reaction or autoimmune reaction had no adverse event. 24% of them had a recurrence of their initial event, and 26% of them had some new autoimmune reaction that was different from their initial reaction. So the bottom line is, with some caution and concern, these patients can be rechallenged with checkpoint inhibitors. Obviously, if somebody has potentially life-threatening disease, you're not going to rechallenge those patients. So the other question that comes up is there any association with underlying autoimmune diseases? So there are case reports of patients, particularly who've had previous thyroiditis or previous autoimmune diseases, who get checkpoint inhibitors and have flares of their autoimmune disease. There was one study that looked prospectively at patients who were getting treated and got baseline ANAs, and there was no association with those patients who had previously elevated ANAs but no specific connective tissue disease, and whether they were going to develop autoimmune reactions or not. And I was just made aware that there is a recent case report of a woman who had acute onset of pneumonitis who was treated with a checkpoint inhibitor and developed pneumonitis seemingly related to the drug. But it turned out she had parakeets in her house and turned out to have hypersensitive pneumonitis that was unmasked when she took the checkpoint inhibitor. Getting back to this specific case that I presented, so the patient underwent bronchoscopy, which was negative for infectious etiologies. He was then treated with prednisone up to 60 milligrams a day, and he went from requiring 90% oxygen on high-flow Optiflow to requiring just 2 liters of oxygen at rest. And so he had a fairly dramatic and quick response to the steroids. This was his x-ray at the time he presented with his acute interstitial lung disease. This was his x-ray and follow-up in clinic, which had a dramatic improvement in the interstitial infiltrates. So in summary, several different things I wanted to bring up. In particular, I want you all to be aware of checkpoint inhibitors. They're going to be increasingly used for treatment of cancer, specifically non-small cell lung cancer, because there's been a dramatic response to pembrolizumab and other checkpoint inhibitors in the treatment of metastatic non-small cell lung cancer. And they're more frequently being used for melanomas, renal cell carcinomas, breast carcinoma as well. So this is a new class of medication that we're going to start seeing a lot more reactions to, and autoimmune reactions to in particular. The autoimmune reactions occur throughout the body, but are a particular concern in patients who have autoimmune-associated pneumonitis, because that's the one autoimmune disease that is associated with mortality. It's difficult to make a specific diagnosis. It requires just an association with getting the drug and the onset of the disease. And bronchoscopy and pathology are helpful only to rule out infection and cannot specifically make a diagnosis of a checkpoint inhibitor-associated pneumonitis. Fortunately, most patients respond well to just not using the medication, and for a small subset of patients who have more severe disease, they seem to respond to use with systemic steroids. And for those patients who do need ongoing treatment, they do seem to be able to tolerate, at least about half of them, seem to be able to tolerate re-challenge with checkpoint inhibitors. So I wanted to thank you all for your attention. I know this is a broad topic that I've discussed today. I want you to remember pneumotox.com. I want you to be more aware of the use of beta blockers. They're safe in COPD, but should be avoided in patients with asthma and COPD-asthma overlap. I want you to think more about non-steroidals and whether people have aspirin-associated respiratory disease, particularly before you refer patients for evaluation and treatment with biologicals, because it is a subset of patients who have severe asthma that respond quite well to desensitization. And with that, I'll stop. I'll be glad to take any questions. Thank you. Jesse.
I had a question about the nasal polyps. I don't think I've ever diagnosed somebody with that. Is that something people are aware of? They can feel it, and you'll see it easily on just looking in the nose, or is that something that you diagnose on a CT scan?
So the question is, how easy is it to diagnose nasal polyps? So first of all, these tend to develop over a long period of time. So I'll see patients who have a very nasal voice, have recurrent sinusitis, and are totally unaware of the fact that they have nasal polyps. But it's those symptoms of chronic rhinitis and chronic recurrent sinusitis that should clue you in. And some of the times you can just look up with an otoscope speculum and see the polyps glistening in the anterior nares. And for those patients that I have had who have had aspirin-associated respiratory disease, they usually have very profound polyps that you can see. But the best way to make a diagnosis is by doing a CT scan of the sinuses. So if you have a patient that you're concerned about having an aspirin-associated respiratory disease, part of the diagnostic workup is getting a CT scan. If they don't have polyps or sinusitis, you can be assured that they don't have aspirin-associated respiratory disease. Other questions? Brad. So the question is if we have a very specific molecular mechanism, why don't we have a specific pathology that goes along with it? And I think that harkens back to when you look at interstitial lung diseases in general, and even patients who have known autoimmune diseases, their pathology can present in a number of different ways. And they can also present with signs of cryptogenic organizing pneumonia, NSIP, nonspecific interstitial pneumonitis. So even with patients who have autoimmune diseases because of their own innate immune system, the pathology is not diagnostic of a specific etiology. The pathology is just diagnostic of a particular pattern. So I think that's true of patients who are exposed to checkpoint inhibitors as well. It's an autoimmune reaction that we're seeing here, and those autoimmune reactions can manifest themselves in multiple different ways in the pathological specimens. Other questions?
Our next one, Tom, and thank you for reviewing the arachidonic pathway. I haven't thought about that for a long time.
I just want to make sure everyone heard that. Thank you for reviewing the arachidonic acid pathway. Wow. Go ahead.
So what's going on, the aspirin desensitization, you mentioned how effective it can be. What's going on in terms of the pathways? What are you changing
So the aspirin in particular totally inhibits the cyclooxygenase enzyme, and it takes about 72 hours for it to grow back, if you will. The symptoms that you get are relatively acute, last for several hours, maybe a day or so, even though that the enzyme itself is completely inhibited during that period of time. So essentially what you're doing is you're inducing a mild asthma attack and increasing asthma attacks till you've gotten rid of the cyclooxygenase, and you now have a refractory period because you don't have any cyclooxygenase left over. So you're basically getting rid of all the cyclooxygenase and continuing to suppress that activity while you're managing that asthma exacerbation that happens along with it. It's not unlike exercise-induced asthma. If an athlete goes out and runs and inhales cold air, they'll have an asthma exacerbation, but if they go run again 15, 20 minutes later, they won't have the asthma exacerbation again. Other questions? Okay, thank you for your attention. Have a good day.